Okay, so welcome to this topic, Principles of Practice in Musculoskeletal Physiotherapy. The reason I put this topic together is just because I really enjoyed the likes of Eric Mader, Jason Turi, John Keeley, Scott Morrison, talking about allostasis and the envelope of function. And this idea of the envelope of function really attracted me because it's just such a simple framework to understand how we treat and assess in physiotherapy. In a world where everyone tries to get so niche and thinks they know, the magic sauce in what to assess and treat. And it's just such a simple way to frame our treatment and assessment. And so this is like a compilation of all of, my understanding of the envelope of function, listening to these guys talk. So physio is hard. There always seems to be no answer. Like when you're looking to the research, it feels like everything kind of works and nothing works. There's really small, treatment effect sizes, and it can be super overwhelming on what to treat and assess. It's like if you think back to like university, and your clinical tutors and your bosses even, and just like what they teach you on everything you can assess, and it feels infinite, like joint mobilizations or watching this person jump and what to analyze and all the different joints. And it just feels like you have to be so skilled and so niche in like a million different assessments. And then at the end of the day, it's almost like none of these assessments really give that much value to how these people have potentially described it as. So that's why I love the envelope of function. And so it's easier to take things back to basics and to think, what do we know? And the first thing we know is that we are all biological creatures at the end of the day. And yes, biology is still very complex, and we do not understand biological processes well, especially in musculoskeletal care, but we do know how some biological processes work, and we have some degree of confidence in how they work. Okay, we're still figuring out a lot, but with some degree of confidence. And just below there's some of the things we'll be chatting about, which you definitely should have heard before. So we've got homeostasis there, mechanotransduction, the SAID principle, allostasis, progressive overload, and physics and biomechanics. So to start us off with homeostasis, a little bit of a throwback back to school or university. So homeostasis is a tightly regulated set of boundaries our body needs to stay in to allow for optimal body system survival and function. So we need to stay within these bounds, and our body will auto-regulate and auto-respond in a predictable manner if we start to venture outside those bounds, okay? Because if we start to venture outside those bounds, cells will start to die, our body will begin to shut down. So we need to stay for survival in the bounds that it set us. So it's reactive. Okay, when you venture outside, it brings you straight back. An example of this, body temperature. So let's say, there's an increase in body temperature. Your thermoreceptors will detect this, and it will send a message to the brain in the control center. And your hypothalamus should process that information and stimulate your effectors, e.g. your sweat glands. So you start to sweat, and also your blood vessels will start to vasodilate. Therefore, more heat will start to be released and your body temperature should start to drop. Okay, so high temperature, and we react to that, and we're brought back into our bounds. Okay, reactive. Now, allostasis, a bit trickier to understand. I'm no expert in allostasis, but this is just my understanding. I'm listening to the likes of John Keeley chat about it. So allostasis is the process by which the body maintains stability through change in response to a stressor. Okay, so it's a fluid set of bounds. It's not constrained tightly to set bounds like homeostasis. If we've got homeostasis here, it will not change those bounds. Allostasis, on the other hand, allostasis bounds will move, and it will move in reaction to the stimulus or the stimuli that's coming in. So then that organism can actually thrive in that environment. Okay, so we're trying to match the stimulus and the organism together to really thrive. Okay, so the body's constantly adapting physiological set points to establish internal conditions best fitting to the current circumstances. It's not a reactive response like homeostasis. It's constantly trying to predict what conditions will best suit the organism, okay? So homeostasis will react to bring you back in, but allostasis will shift. It will shift to try and get you in the best situation possible. And so you have your allostatic bounds, an incoming stimulus, which you maybe have had prior experience in, so it will shift and allocate resources. And it's going to allocate resources based on factors such as neurobiological and immunobiological states, which are then influenced by things like lifestyle, stress, metabolic health, psychological state, and training loads. Okay, so if those things are running with really high resources, like you're really super healthy and you have, not much stress, low training loads, your body will be able to easily allocate those resources. But someone who doesn't have, such healthy lifestyle, things like that, you won't actually be able to make that resource allocation as easy. Okay, so and then your allostatic bounds will shift and adapt. Now, so let's see how it's different to homeostasis there. Now, it gets a little bit easier if we use it in an example. So if we're training at the gym consistently, I like to use this as an example. So the central nervous system will predict the incoming stimuli from past experience of cellular stress. Okay, so you've gone to the gym before, you've done a smashing workout, your biceps or something, and you're about to start a bicep set at the gym, and your body's already predicted this from incoming stimuli of past experience of that cellular stress. So the central nervous system will adjust mediators by mobilizing a diverse breadth of neurological, biological, and immunological accommodations to counter these emerging challenges. So such as the hormones of the HPA axis, catecholamines, and cytokines. And then the capacity to make that resource accommodation, like I was saying earlier, it's all affected by your lifestyle, metabolic health, psychological state, and your training activity. Okay? And to make it a little bit easier, I made a little meme here. So we've got Big Doggo, who trains at the gym after a rest day, and he had a rest day yesterday. He had a good night's sleep. He eats healthy, not smoking or drinking. He's expecting good gains. He knows this bicep curl is going to be very beneficial. It's going to probably give him some hypertrophy. Now, there's little Doggo here who isn't doing as well from an allostatic state. He's actually doing daily random exercises that the physiotherapy might have given him. They're sort of hurting him. He's not sleeping very well. He's trying to find employment, and also to top that off, he's in the doghouse with his partner. So these two doggos could be doing the exact same program or the exact same workout, but both will probably adapt to the stimulus. But Big Doggo will probably adapt more favorably because he actually has more resources to accommodate to that allostatic shift. Okay, and that actually reminds me of a study. Can't remember quite when it was done or the authors, but they took, my understanding was they took two twins, identical twins, and they gave them the same program, and I think they tested strength at the end of it, and one had significantly different strength gains to the other. And these twins have the exact same genetic makeup, obviously not epigenetically, but they have pretty much the same genetic makeup, and they've had two different adaptations to the same stimulus. So it's just funny that when we try and make these programs for people, how do we expect two people to react the same? It just doesn't make sense. So yeah, and then you can also think that allostasis is predictive. Where else have we heard of this predictive theory before? And it's in the Bayesian brain. It's in what we think how pain sort of works at the moment. So this isn't new stuff. The predictive processing model. So this stuff is happening potentially from a Bayesian point of view. Okay, so allostasis simply. We have an allostatic state which determines what resources we will allocate to an imposed stressor. You can pause the video. This, when I was researching a little bit, I did have to come across some figures so I could really put it together in my brain. But if you want to have a pause and look at some of those to help you understand it, there it is. I won't go through it though. Now, if you get a little bit more simply now, we'll go into progressive overload. So That's systematically increasing the intensity, volume, or difficulty of your workouts over time, so then you can gain adaptations from training. And we do this, and then mechanotransduction occurs. So this is the process by which cells convert mechanical forces into biochemical signals that influence their behavior and function. So we utilize progressive overload so that mechanotransduction can occur. And then if we do progressive overload in a specific way, then we know that the said principle will always apply. And the body adapts specifically to the type and intensity of stress placed upon it. You do bicep curls, your biceps are going to get bigger, not your calves. Okay, so that's the said principle in a nutshell. And then this new principle, I guess you could call it, or framework, is the envelope of function. Now, this is probably new to a few people, and this is the range of load that can be applied to a structure without causing structural or metabolic failure. But let's go into the envelope of function now. And this was proposed by Scott Dye. He was an orthopedic surgeon. I think it was pretty specialized in knees. And this was, I want to say 1996, but I'm not sure off the top of my head now. But this is what the graph looks like. And this is, he made this in relation to knees, actually. But it can actually just be used so much wider than just knees. So let's break this down. So on the y-axis, we've got load, and that's the amount of force applied to a structure. And then on the x-axis, we have frequency, which is the frequency or duration you're loading that structure. Then we have the line, the envelope of function line, and this is the tissue's current capacity to undertake load. Okay, so the structural limitation of that tissue. Now, just sitting below that envelope of function is the zone of homeostasis. Now, when we do activities in this area, the tissue is very happy and is doing its job in this area, okay? We're not underloading it, we're not overloading it, we're doing just the happy amount that our tissue is used to doing and is prepared for. Now, when we go creep above that envelope of function line, we get the zone of supraphysiologic overload. And this is when we start to exceed structurally what the tissue can tolerate. And this is when we're starting to ask the cells or the tissues to start to adapt to the new forces we're putting on this tissue or structure. And this is utilizing mechanotransduction when we train and we do an activity above the envelope of function. But if we creep too high, or maybe if our allostatic loads are low, our allostatic loads are high, and you know, we accumulate too much stress, maybe in the supraphysiologic overload area, we start to creep into the zone of structural failure, and this will exceed structurally what the tissue can adapt to. Tissue is unable to adapt to these loads, and it will probably cause the tissue to break down and to fail. And like I was just saying before, that dot point, it's likely secondary to loads being too high, and this could be allostatic loads or mechanical loads being too high. Last but not least, the zone of supraphysiologic underload. So when we don't use the tissue, you don't use it, you lose it. Everyone knows that principle. And so if you don't use it, the body's just going to reallocate those resources elsewhere, okay? And it's going to take away from that tissue's envelope of function. If we sit in that supraphysiologic underload for too long, our envelope of function will start to shift. And here's an example in terms of knees, right? Some examples of activities. So the general rule of the envelope of function is that if we load with little frequency, that means you can tolerate higher load activities. But if you load with higher frequency, you can only tolerate lesser loads. So if we just think about some of these activities here, you got on the left-hand side, quite high up on the x-axis, we have jumping from a 2-meter height. You can probably tolerate a few of those, but if you start to accumulate that, you're probably going to start to exceed the envelope of function, aren't you? Again, walking 10 kilometers. Walking in itself, pretty low load, but when we start to creep up there, over 10 kilometers maybe, if in an untrained individual, that's going to start to creep above that person's envelope of function, okay? So I'd like to propose a new line also in the envelope of function called load tolerance. Load tolerance could be how much of that load you're willing to deal with. So how much load the human or the person is willing to deal with. If we think back to the envelope of function, that's the tissue's current capacity to undertake load, and it's the structural limitation of the tissue. It's a very peripheral way of thinking of, you know, overloading and tissue damage. Load tolerance is more of like a human's ability to cope with that load, okay? So I'd like to play a little bit of a game now. I've done some really magnificent lines there, and I've drawn an enveloper function, a baseline, a new enveloper function, and then that person's load tolerance. And I want us to think about what presentation could walk in the door with this type of enveloper function and load tolerance. So if you want to pause the video, have a go yourself, but I'm about to give it away now, what this one might represent. So if we're looking here, this person has high capacity and low load tolerance. So by high capacity, I mean that their enveloper function still remains quite high. It's dropped a little bit, but it's still quite high. But we definitely have super low tolerance, right? There's lots of different probably presentations. I've just given a couple examples here. So if we think of in an acute injury, this could probably represent an acute injury because let's say an ankle sprain for now. So if you have an ankle sprain, okay, 1 or 2 days later, let's talk about the calf in the context of an ankle sprain, the calf muscle complex or the plantar flexors. So obviously in 2 days, the plantar flexor enveloper function is not going to deteriorate or decondition that much. You know, you're not going to lose strength, peak force capacity in 2 days. However, the ankle is going to be so painful, right? So obviously that load tolerance is going to be low when we start to do plantar flexion as a movement, but it's not because we don't have a lot of high strength. It's because we are limited by pain, right? And another option could be post-surgical, and I'm not talking about the surgical site. I'm talking about the muscles around that joint or that surgical site. So if you think of like a patella tendon repair, obviously again, if that only has just happened, the quadricep muscle bulk is not going to be deconditioned very fast. So that enveloper function is going to be restored in the coming 2 days after post-surgery, but that load tolerance is going to be super low because you've just been cut into. You're going to have a super low load tolerance for doing a knee extension, right? All right, so now I got the gist of it. Let's do the next one. What do we think this one might be? Okay, so I'm going to give it away now. We've got a graph, an enveloper function that's saying low capacity, low tolerance. Okay, so that baseline, the enveloper function has dropped real low past that baseline, and yet our load tolerance still remains quite low, even below our enveloper function. So you could think about this in the case of chronic pain, okay, where a person has been in pain for so long that they might remain quite sedentary and let's say lower back pain, and they become quite sedentary, and therefore they are sitting in that zone of supraphysiologic underload for too long. They get resource allocation that you don't use it, you lose it. That envelope function creeps right down, and unfortunately in their case, because it's chronic pain, it's still going to remain super painful, and sometimes when you're in that much pain, you can't even creep above your enveloper function to get adaptations, okay? Because you're scared of this pain. You don't want to work into this pain. So could represent that. But also we could go back to our post-surgical and think of the post-surgical site itself. So let's think patella tendon repair again. Let's think about the actual patella tendon. So that tendon, because it's been cut into and repaired, it's now structurally quite poor. Its capacity is quite poor, that tendon. So we have lost a lot of its enveloper function, and it's going to be super sore because it's just had surgery. So you're going to have a really poor load tolerance as well. So that's what that one could typically represent. And now, I think second last one. I like to put this in my trick question one, but this one's someone with high capacity and high tolerance, and this would be just someone who trains. This is how we'd ideally want to see an enveloper function, how an athlete would train. We have our baseline enveloper function, and we're getting better because we have a new enveloper function. and our load tolerance sits above our envelope of function. That means we can actually train just a little bit above our envelope of function into that zone of supraphysiologic overload where adaptation should start to occur. So an individual who trains on that one. Okay, last one. So this one represents someone with low capacity and high tolerance. So this can maybe represent those boom bust athletes or those previous injuries with rest and no rehab. So if we think about this one, we have our baseline envelope of function and it has significantly reduced. However, our load tolerance is still pretty high. So I think a good example of this one is like a bony stress injury. Like a lot of athletes are super happy to train, pretty high above their envelope of function because it doesn't hurt them so much. So what they'll do is they'll keep training, and then they'll eventually start to creep again over that envelope of function into over supraphysiologic overload, into structural failure. And then that's going to keep creeping that envelope of function right down. So this can explain so much. We can use the envelope of function to explain maybe why people are getting pain and why some of these pathoanatomical reasons for pain are not so true. I heard Eric use this in one of his podcasts, but he says it hurts. One of his patients came in and said, it hurts my shoulder when I reach behind my back and do my chores and I don't know why. And my doctor said I have shoulder impingement and when I'm sweeping the floor, my shoulder is impinging and that's why I'm getting pain. And then you do a thorough history on this patient and the patient says, oh yeah, 2 weeks ago I was actually working overhead, I was painting. And they cannot recall the last time they even had to work overhead for that long. Okay, so yes, the shoulder probably is impinging when the patient is sweeping. And like we know with shoulder impingement, it happens in, I think, over 50% of asymptomatic individuals, we have shoulder impingement occurring. And did the impingement cause the shoulder pain? No, the impingement isn't causing the shoulder pain, okay? That impingement was probably happening in the patient before this episode of pain. So the impingement isn't the problem, it's the increase in load that exceeded the patient's envelope of function. Now that envelope of function has decreased and simple chores that were once within the envelope of function sit outside the envelope of function. Because there's nothing inherently wrong with sweeping or impinging, it's just now sitting outside your envelope, these activities. And if we look at this visually, we can see it. So maybe this patient, this is prior to the injury, so sweeping for 1 hour sits well within their zone of homeostasis. Their shoulder is super happy doing this. It's under their envelope function, it's under their load tolerance. But then that person goes and paints for 4 hours and that exceeds both the load tolerance and the person's envelope of function. Now, all of a sudden, the envelope of function probably doesn't change that all that much, but maybe you've exceeded, the supraphysiologic, you've actually gone into the zone of structural failure and that's caused your load tolerance to creep down. And now sweeping for 1 hour, that's actually sitting on or outside your load tolerance. Okay, so there's nothing wrong with sweeping, it's just now not sitting within your envelope of function. And now if we use another example, going into knee valgus is bad during a squat. Okay, yes, knee valgus increases the loads at the patellofemoral joint, and yes, taking someone out of knee valgus, it might improve someone's pain, but did the knee valgus cause the pain? No, okay? Changes in loading have increased the knee's sensitivity to load. So maybe again, that person has accumulated too much load and now their load tolerance has dropped, the envelope of function may have dropped, and now the knee is more sensitive to load, therefore decreasing the person's envelope of function. And now the knee valgus is just the straw that's breaking the camel's back, okay? When you now change the knee valgus, you're deloading the squat enough for the squat to remain maybe in the person's envelope of function now, okay? So you're doing a symptom modification to deload some of the knee. However, that's not because the knee valgus is bad, right? You're just doing a nice symptom modification on that task. So then we want to use this model. Okay, so how are we going to use it? First of all, we got to decide, is this patient suitable for rehab? Okay, so we want to rule out all those red flags. We want to onward refer if we need to. Then we need to look at this patient. We need to think, how confident am I that I can intervene and change something that needs to be changed? Okay, so is this something that I can change? And do I think that this change is necessary for this person to get better? Okay, because if it's not, then why are you rehabbing them? Well, what are you trying to do? Okay, so it's some things that we might find, especially using this model, is quite easy to change, is someone's load profile, someone's load tolerance, or someone's capacity. And they're three major things that we can try and change. Okay. So then we want to create a targeted intervention. We need to think, what adaptation am I trying to get from my intervention? So we need to think, okay, this person presents to me. Is this something that might be a capacity issue? Like, do I think this person's got quite low capacity? And if I increase this person's tissue capacity, then they will potentially get better. Okay. In that case, if I'm trying to get capacity gains, so strength gains, especially if we're thinking muscle and tissue architecture, then I probably want to choose resistance training. And we know we've got a pretty good idea that if we want to get gains from resistance training and get gains in strength or hypertrophy, then we probably have to dose it a specific way. We probably have to train at least once a week, and we need to, train a few sets of that, and we need to probably train with no more than 4 repetitions in reserve, and then we will probably get an increase in capacity. Okay, but then if we're thinking, oh, you know what, the person's capacity, it's probably not so much of an issue. Like, it's always healthy to increase someone's capacity, but what if the main thing we're trying to treat at the moment is load tolerance, because the load tolerance is probably sitting below their capacity? And then in that case, we get a lot more freedom in how we can dose if I'm treating load tolerance. So I'm treating pain essentially. And we know for pain, there's no real answers on how to dose for pain. It's completely up to the physiotherapist, and you can dose completely on the individual, and you can do whatever intervention you feel is appropriate, and you just need to dose it to that individual. So there's a lot more freedom there if we're trying to change load tolerance. Okay, and unfortunately we can't be as confident at predicting outcomes when we're changing that. And obviously if we're trying to change loading, we can just do a really thorough loading profile and program accordingly. So we need to then, this is where this envelope of function model cops a bit of critique. So it cops a bit of critique because people say, oh, it's really peripherally driven, pathoanatomical reasons for pain, like it's not all about the periphery. No, you're right, it's not. But this model can incorporate allostasis and the principles of allostasis into it. So we need to understand that allostasis and biopsychosocial factors will influence someone's envelope of function. So if someone has a super high allostatic load, okay, then they're not going to be able to adapt to loads as well. Okay, so if they've got really poor metabolic health, stress, lifestyle, all that stuff we're taught about that influences pain, they're probably going to have a lower load tolerance, a lower envelope of function. Okay, so we can really incorporate allostasis into this model, especially if we use that extra line that we created in this called load tolerance. All right, so I wouldn't be so quick to critique it. We can work in the biopsychosocial and allostasis model into it. All right, and then the last thing is we want to do is we want to track progress. And the way we can do that with subjective asterisk signs, obviously. So you can get, for example, pain intensity, task intensity, load profiles. But then obviously we want to track objective measures. Okay, we want to track and definitely see if our intervention is having the effect we want it to or we're trying to achieve. So if, like I said before, we think this is a capacity issue, we want to make sure that this person's capacity is increasing. And this is why we love dynamometry, Mitch and I, because dynamometry, it can track capacity, okay? You can do isokinetic, isotonic, isometric force tests. And that will hopefully give you a pretty good alias for someone's capacity. But dynamometry can also give you someone's load tolerance. What if you just say knee extension, just push in to where you feel comfortable, where that pain starts to get a little bit uncomfortable. We're getting a picture of this person's load tolerance of the knee extensor mechanism, right? So dynamometry can capture both load tolerance and it can capture someone's capacity, and that's why we love it so much. Obviously, you've got all the other objective measures as well. Now this fits really well into this next slide. I'm sorry, Mitch, but I did have to steal this off your hamstring presentation that you're going to upload in the future. It's just so good. So this idea of making sure when we, treating someone, we are trying to pick low-hanging fruit and do this before we pick the high-hanging fruit. So we need to do the easy stuff exceptionally well, as in as best as we can do it. Smash out the low-hanging fruit. Pick all of the low-hanging fruit before we start picking that high-hanging fruit. What do I mean by low-hanging fruit, high-hanging fruit? Low-hanging fruit is easier to quantify and meaningfully change. So, neuromuscular capacity as an example. Using dynamometry, we can actually calculate peak force and we can track that quite easy and quantify it over time. We can see if our intervention is improving, okay, and if it's changing. Another example of that is load tolerance, okay? We can do that with dynamometry as well. Another example is someone's load profile. We can track someone's load profile over time to see if that's gradually increasing. We are intervening and assessing the things that we can meaningfully change, okay? Now, things that are, after you do all that low-hanging stuff exceptionally well and you're still not happy with the outcome, that's when you can start picking the high-hanging fruit. Now, the reason it's high-hanging fruit is because it's hard to quantify and meaningfully change. So motor control, right? So motor control, a little bit contentious, but motor control, I'm not happy that we can, first of all, reliably measure it, especially with our eyes. I know when we use gold standard 3D motion capture analysis, that does make it a little bit more reliable, but there's still a considerable amount of error there. But what clinics have that anyway, right? So I need to be convinced that we can, reliably actually track motor control and measure it, which I don't think we can yet. Reliably then intervene on it, and then for it to transfer into the person's sport or activity, which we haven't actually achieved yet, and then predict that is going to be then a risk factor for injury, or it helps improve performance. Okay, so that stuff, it's hard to quantify and we don't know if we can meaningfully change it yet. I'm super happy if we want to try pick some of that high-hanging fruit, but there's no point of picking it if we haven't picked that low-hanging fruit yet. So just want everyone to sort of understand that idea, and we're going to bang on about it in pretty much all of our little topics here. Okay, so then lastly, this envelope of function, you technically could zoom in really far with it. You could think every single cell has an envelope of function. You could think every single cell at a different range of motion has an envelope of function if we're thinking musculoskeletal system. I heard Jason Turi would say, every single blood vessel cell has an envelope of function. It's not just musculoskeletal. Every single cell at a different allostatic variable then has an envelope of function. It doesn't really help when you zoom in that far, but how I like to use it is when you zoom out and you might say, I'm looking at the envelope of function of the plantar flexor mechanism or the extensor mechanism at the knee. And then that's when you can start using this model, and it can be quite handy. We can even zoom out even further and think the human envelope of function. So like maybe that person's exercise tolerance. So that's when it can start to get quite handy, I think. So hopefully this topic has really helped bring some things into perspective, and you can understand that there's no magic sauce and that you don't need magic sauce to go treat someone or assess someone. You don't need to know about every single joint mobilization at every single joint and every single grade. or how to reliably, with just your eyes, assess someone's jump and change their mode of control. Just think about it really simply through the lens of the envelope of function, and I think you will tend to have quite a bit of success. All right. Let us know if you have any questions. Flick us an email or chat to us on Instagram, and we'll do our best to get back to you. See you next time.